And you get, if you push it in all at once, you get much higher levels, don't you?
Objection, vague.
Sustain.
Or you get a much higher blood level, don't you?
Objection.
Sustain. Over what time frame? It's vague and ambiguous.
I thought I clarified that, Your Honor. I'll re-ask it. If you push it in all at once, not the minute to a minute and a half that you're talking about, but just like giving somebody a flu shot, all at once, that can cause resuscitation or apnea. Isn't that correct?
Objection, vague.
That was asked and answered. The other question had to do with blood levels.
Okay.
That was the issue.
Okay, that would give a high blood level, higher blood level than you're trying to achieve, wouldn't it?
Objection, vague, speculation.
I think it depends over what time frame. Sustain.
All at once. If you push it in all at once, I'm just like giving a flu shot. If you push it rather than infiltrate it over the minute to a minute and a half you're talking about, if you push it all at once, you're going to get an undesired blood level, aren't you?
What I would say is, in my practice, when I use propofol, my typical practice of infusion is to infuse it over a minute to minute and a half, in part because I will assess the patient as I'm infusing the medication. And if the patient is relatively sedate and I do not need to give a whole milligram per kilogram, I will stop. I do not give it IV push immediately. So I can't really tell you specifically what that's going to do to the blood levels, but...
So you don't know if whether or not there's a difference in danger to the patient, whether it's pushed all at once or pushed over a period of time?
Not specifically.
And you've never seen it done?
Not in my practice, no.
And you've assisted other doctors, and you've never seen it done where it was pushed all at once, have you?
Okay. Now, when we do procedural sedation propofol, I am usually the one to push and administer the medication. If I am teaching a resident, I instruct the resident on how to administer it.
And when you're instructing them, do you tell them what the consequences could be if it was pushed all at once?
If a patient, in reality, if a patient is oversedated, I can manage it, but our goal is to sedate the patient to do the procedure. I do not give a lecture on if you push it all at once, what happens, if that clarifies.
So when you're training the residents and the administration of the propofol, you don't tell them why it's got to be done over a period of time?
I guess with most things I would describe, we want to get the level, we do actually want to get the levels up to a high level fairly quickly as opposed to over a protracted period of time, because you want to achieve a deep enough sedation level to achieve the procedure.
Well, when you say you want to get the levels up fairly quickly, is that what you're describing when you talk about a minute to a minute and a half?
Mm-hmm. Yes.
Okay. Why don't you want to do it quicker than that, like get it up in 5 seconds?
Because I may not need to give the full dose of drug that I've administered, because as I give the medication, I can determine how the patient's responding. So if the patient is having an adverse reaction, I have not given the whole dose of medication.
So the only reason you don't give it in a bolus push is because you're not sure how much the patient needs.
Well, I also give it over a minute to minute and a half because that's the general instructions of how to use the medication.
And you don't know the reason for the general instructions to do it over a period of time.
Objection, misstates your testimony.
Sustain.
Do you know the reason why you're instructed to do it over a period of time as opposed to all at once?
I reported this is why I do it, because I want to see the response and see how sedated the patient becomes.
And that's the only reason?
What are the reasons specifically?
Would it be dangerous to do it all at once?
Objection asked and answered.
So overruled. You may answer.
I suppose if you go get such a level that was so high, especially if you were giving a large dose, yes, that would potentially cause more sedation than you anticipated, or deeper sedation.
Okay. Well, the 60 milligrams that you use, if you did that all at once, would that be dangerous?
Objection vague, speculation.
I'm going to sustain the objection on 352 grounds. I've allowed counsel to reopen. We're approaching the limit. Thank you.
Now, whenever you use propofol, you typically have all of the equipment that's available in this surgical suite here, or this trauma bay center?
This trauma bay has a number of other equipment and modalities that are not really relevant to procedural sedation. So no, I do not have all of that available to me.
Okay, but you've never given propofol outside of a surgical setting, a surgical suite?
I do not work in a surgical suite. I work in an emergency department.
Okay, and the emergency department has basically all the stuff you have in a surgical suite, doesn't it?
I can't speak to what is in a surgical suite.
Okay.
In the emergency department, I have monitors in every room. I do not perform procedural sedation in a room that does not have a monitor. And when we perform procedural sedation, we have airway equipment in the room and set up, because that is our policy, to have that set up before we start any procedure.
When did you start administering propofol?
Objection relevant.
In terms of year?
I'm going to sustain the objection on 352 grounds at this juncture. Thank you.
All this equipment that you've identified up here in this trauma bay, such as those computers where the IV bags might hang,
Yes.
how long have they been there?
Objection relevant.
Sustain.
Is this new equipment?
Objection relevant.
All right, I'll overrule the objection. Go ahead, please.
Everyone at work is going to wonder why I don't know this. I don't know exactly when we moved into the new Ronald Reagan Hospital, but a computerized pump or a pump is something that is standard in practice in the emergency department. And in my entire career, through my training, we have pumps that we can control the rate at which medication flows, whether it was computerized or what type of a specific brand, or if it was that machine. I couldn't tell you how long.
Whenever you administer IV medicine, is it always through a pump?
No.
And administering propofol, has it always been through a pump?
When I administer propofol in procedural sedation, it is not through a pump at all. As I said, I administer it myself slowly as a push.
That's just with a needle?
We use a needleless system, but yes, it is connected to the HEP lock.
And that's that little lock on the IV tubing that goes to the patient?
The patient will have a catheter, a tube in their arm. At the end, there is a cap. I will connect to that cap it's a wireless, needleless system that we will connect through. There's sort of like a rubber hub. I will then infuse the propofol that's in a syringe that I've drawn up through the IV.
So you don't use those pumps for propofol at any time?
Objection misstates the testimony.
Sustain.
What are those pumps used for?
Those pumps are used to control the flow of medication and the rate of medication so it would depend on the type of medicine and whether it needed to go in over a certain period of time, or if someone was on a continuous infusion and we wanted to control that infusion.
Do you use propofol on a continuous infusion?
In some rare circumstances, yes.
It's not normally used for procedural sedation that way, though, is it?
If a patient, that would not be procedural sedation. That would be used for deep sedation in a patient who has been intubated and is on a ventilator.
Okay. Nothing further.
Mr. Flanagan, thank you. On redirect, please.
Thank you. Dr. Cooper, in deep sedation, where you're going to have a continuous drip or infusion of propofol, you would rely on the infusion pumps, correct?
Correct.
Okay, and those would monitor precisely the dosage, the amount of propofol flowing into that individual's body, correct?
Correct.
Okay, now you indicated that when if a patient was over-sedated, you're able to manage that situation. Do you remember that answer to Mr. Flanagan's question?
Yes.
Okay, and the way you're able to manage that situation is because you're in a hospital setting with all the necessary emergency equipment and airway equipment to manage that type of consequence, correct?
Correct. And I'm an emergency physician, and so I have the skills to intubate a patient and to actually obtain an airway if that is so necessary, yes.
Okay, and you're prepared for that consequence?
Yes.
Thank you. Nothing further, Your Honor.
Thank you. Any on recross, Mr. Flanagan?
Have you ever...
Yes, please, from the podium.
Have you ever used...
Wait, if you could just wait till you get to the podium, please. Thank you.
I'm sorry, Your Honor.
That's okay.
Have you ever needed to use those skills during a procedural sedation?
Objection to relevance.
Overruled.
I've never needed to intubate a patient, but yes, I have needed to attend to a patient's airway during procedural sedation.
And in tending to a patient's airway, what have you had to do?
So the first thing you'll do is stimulate the patient, because if you can wake the patient up and they're just not breathing, usually you will catch it before they stop breathing. That is the goal. I've never had anyone stop breathing during procedural sedation. But generally, people's breathing is insufficient. So if I can stimulate the patient, they will generally take deep enough breaths. That, with oxygen and repositioning the airway, is almost always sufficient.
And if a person had a problem when you were administering the propofol, it's something you would see right away, isn't it?
Yes, that's why you are monitoring them, why me as the physician and the nurse is monitoring the patient.
So if you took 60, I think he said 60 milligrams for a 60-kilogram patient, and you started administering it, you could see if there was a problem developing right away, couldn't you?
Typically, yes.
And what would the signs be that the problem was developing?
A problem of oversedation? Is that the question? Because there could be other problems, an allergic reaction, some other unexpected reaction.
Okay, well, you've never seen those happen, have you?
I usually screen patients so that I do not perform procedural sedation in someone who may have a problem, may be allergic.
Is that a no? You've never seen that?
Other reactions? No.
Okay. Now, the one problem that you could that you might see would be a breathing problem.
The common problem, the first problem you'll see will be oversedation, which would result in respiratory insufficient breathing. Yes.
Okay, and you could determine that by just seeing the patient, couldn't you?
When you're doing a procedure, you may miss something when seeing the patient. That is why we have a monitor that monitors their pulse oximetry, capnography, which will pick it up often before humans will detect or notice there's a problem.
But you shouldn't actually be doing the procedure and controlling the propofol also, though. That's for separate people, isn't it?
That's why there is a separate person to perform the procedure, and I, as the attending, attend to the procedural sedation.
Okay, so when you administer propofol, 60 milligrams, you wouldn't be doing the procedure also.
No.
You would just be concentrating on the patient.
Yes.
And if there was a breathing problem, you could readily determine that, couldn't you?
Yes.
And you could readily determine it by just looking at the patient, couldn't you?
You still may miss because people who are sedated will breathe less, but if you're breathing 8 times a minute as opposed to 16, that may be sufficient. Versus if you're breathing 8 times a minute and you're not breathing deep enough, your oxygen saturation may start to drop. And even watching the patient, there are potentially problems that you will miss. That is why we monitor as a fail-safe, and we have 2 people monitoring.
Well, when you say you could miss it, you could miss the first sign, but you would see it within a couple minutes, for sure, wouldn't you?
You would see it before a couple minutes.
And so if a person was infusing over a 3 to 5 minute period of time, 25 milligrams, and there was a problem with that, that would be easy to determine, wouldn't it?
If you're asking me, if I was watching a patient and monitoring them, and they had a problem, would I notice it, or would the computer or the monitor alert me to there being a problem while I'm doing my procedural sedation? Either me or the monitor or the nurse who was monitoring the patient would identify the respiratory depression before it became a problem, yes.
I mean, and you would identify it without a monitor, wouldn't you?
I would hope I would, but I have a monitor and an additional person so that I do not miss it, because that is the danger in performing procedural sedation and why it is restricted.